It's 18:02 here in India, and I want to welcome everybody to this edition of our Lancet Commission webinars. I'm Nachiket Moore. I am a commissioner on the Lancet Commission for a Citizen-Centered Health System for India. The commission is a cross-sector participatory initiative to develop a citizens' roadmap for universal health coverage, convening leaders from academia, civil society, government, and the private healthcare sector, and grounding its work in public engagement. I want to welcome you to another edition of our webinar series on key health system challenges facing India. Our topic of today's discussion is the centricity of operative care to health systems. As we consider universal health coverage, we rightly focus our attention on issues such as public health and primary care. But we often tend to overlook the fact that a comprehensive, high-performing health system has an obligation to provide the full continuum of care. And that continuum includes surgical care. That we in India have a journey to complete on this front is apparent from our C-section rates. While there are no absolute standards against which these rates can be judged, we know from evidence that on average, about one in every 5 women will derive benefit from operative care of some sort during her delivery. Against this measure, over 250 districts in India have a total C-section rate of under 15%, with 40 of them below 5%. The situation as it relates to other essential surgeries is much, much worse. It is clear that without ensuring that there is an adequacy of surgical care available, India's quest for UHC will remain incomplete. And that as we work towards strengthening our health systems, we cannot afford to ignore the urgent need for expanded access to surgical care. To discuss this issue, we have with us 3 very distinguished speakers. I will introduce each of them and then proceed with an initial opening question before turning to the next speaker. To begin, I want to start with you, Professor Justine Davies. Professor Davies is a professor of global health at the University of Birmingham in UK and director of the WHO Collaborating Center for Emergency, Critical, and Operative Care. Her research focuses on developing health systems that deliver quality care in lower or middle-income countries. Her research involves examining the health of the population and the health system that serves them from multiple angles, including epidemiological, qualitative, and systems readiness, and economic perspectives. Professor Davies, as you are aware, the Lancet Commission on Global Surgery had set a target of 5,000 major operations per 100,000 population. I was curious to learn how this target was determined, and given India's reality in terms of human and financial resources, as well as that of many other countries, I'm sure in Africa, where you are right now, as well as the fact that approximately 70% of our population lives in rural areas, what would be the most effective way for us to achieve this target? Professor Davies.
Thank you very much. That's the $1,000 question, isn't it? Yeah, I started the Lancet Commission in Global Surgery in 2013, and we did indeed come up with that figure. Since then, I've been dismayed, I think, I'm choosing my words carefully, to see that progress to achieving that figure of 5,000 per 100,000 has been slow, if not backwards. And we published a paper, a follow-up from the Lancet Commission in this year, which, and I'll quote from it, said that progress towards the Lancet Commission on Global Surgery's 2030 targets has been too slow and too patchy, particularly in LMICs. We also said that the unmet need for surgery has continued to grow. So it's not gone away. And then on top of that, the question is, how can India achieve those targets? And especially when a majority of the population or a large share of the population live in rural areas. You've also mentioned universal health coverage. And as we're all aware, universal health coverage the package of interventions which are universally covered varies from place to place. And ideally, countries can cover everything using universal health coverage. We all know of the situation in the UK, where our health system, which intends to have universal health coverage, is failing to achieve that. Some countries, for example, Rwanda, are achieving universal health coverage on paper, but then you look at their metrics and one begins to question that. So how can India achieve that when so many other countries have attempted and failed? I should also say, mention here the cost of including surgical care in universal health coverage packages. I believe the National Surgical Obstetric and Anesthesia Plan for Nigeria was costed at $15 billion to achieve that. And this is against a health budget in Nigeria of $3 billion. I think there are several vehicles to achieving universal health coverage, including surgical care. And the first one is not to do everything all at once. Surgeons are brilliant at wanting to achieve results. They're classic type A personalities. And sometimes I think in the surgical world, the perfect becomes the enemy of the good. And achieving a basic package of surgical care is a good first transition step towards expanding that. If we try to be Nigeria and have a comprehensive package, it sets us up to fail because we can't do that. Nobody will start if the bill is 15 billion. Hey, the other thing that I think that one can start to do, and this includes folding in people from rural areas, is actually considering surgery not as surgery, but surgery is of and for the health system. So if one can provide surgical care, it's not just for surgery, it is for all other elements. And this includes for people who live in rural areas. So considering surgery as part of the health system and considering the interactions between factors needed for surgery, like CT scanners, like anaesthetists, like physiotherapists, occupational therapists, and actually not considering those in isolation, but what benefits they have for the whole system, I think will get us a lot closer to providing surgical care for those who are need it. I mean, that's what we're ultimately after, is anybody who needs surgery care should have access to safe surgery care. So the isolationist approach that we have had with surgery, I think needs to go. We need to consider this as a health system intervention. It's not surgery. And starting small and growing big, I think it is also where we need to go. So that's my answer in a nutshell. I'm not going to take up too much time, but I'm hoping that we can expand on that as the time goes on.
No, thank you, Professor. That's a very, good piece of advice to us as a commission that's thinking about India and UHC as a whole, as well as, to our policymakers who are, aspiring to get us there. I wondered though if, you felt, you mentioned Nigeria, but I've always believed that we in India have somewhat of a unique position, relative to many other countries, in that our production of human resources for some of this work, local production, is quite high. To the point, while I mentioned that more than 200 districts have C-section rates of less than 15%, it is also the case that 250 districts have C-section rates above 25%. And there are, I think 50 districts where the rate has crossed 50% in the public sector and the private sector, not just in the private sector, which suggests that maybe we do have nationally that capacity somewhere, but we are deploying it excessively maybe in some parts and not enough in other parts. I don't know how you'd react to something like that. This may not be true maybe for African countries where they don't have local production to the same degree, whereas we do.
Yeah, I mean, so human resource planning is notoriously difficult. We had, again, I reflect back on the UK because I like to air our dirty laundry in public. But I reflect back on in the UK when I wanted to become an obstetrician and gynecologist. That was the thing I wanted to do. But at the time, the UK had overtrained O&G professionals. And so even in a country where there was close monitoring, close projection of needs, there was a mismatch, and it sounds like there is a mismatch within India, at least for C-sections, and that will creep into other areas, and I think that detailed projection of needs is required. Maybe also some services are more enticing than others. So incentives, again, might help to even out the human resources. Again, airing our dirty laundry, we have a national system whereby people apply for jobs, and people are actually allocated jobs in places that they might not want to work in, which does spread things out a little bit more. But it is difficult because people are people. They don't like to be told what to do, and you'll be more aware than anybody that if people are forced to do something that they don't want to do, especially in a country like India, they can leave, and there will be brain drain. So there needs to be that balance between planning, incentivization, carrots and sticks, and also making sure that people just don't go elsewhere to work.
Indeed. That's wonderful, Professor Davis. Thank you so much for your initial remarks. And we'll be sure to come back to you once we've gone around the panel a little bit and heard everybody else's views. So thank you so much for this. I want to now turn to Professor Martin, Janet Martin. Professor Martin is a professor, Department of Anesthesia and Perioperative Medicine, and the director of the Center for Medical Evidence, Decision Integrity, Clinical Impact, short form MEDICI. That's wonderful. I love this short form. At Western University in Canada. Professor Martin's work focuses on evidence generation, implementation, and policy development for anesthesia, perioperative medicine, and critical care in low, middle, and high resource settings. So, Professor Martin, a question to you to begin our dialogue. One of the issues that I think you've spent some time talking about, and it's something that engages us, which is building measurement-driven perspectives on operative care. And it is challenging for LMICs like ours, which, because of a variety of issues, including budget constraints, inadequate underlying data systems, we've struggled to get basic data on a number of parameters, including surgeries, in a high quality manner. Also, I think sometimes, policymakers, decision makers have the view that how will this kind of information, particularly on surgeries, be helpful to improve efficiency and quality? How do you think countries like ours should go about building these data systems that maybe don't require, a very high level of investment, because that will then make it hard for us to move forward and then find, a way to improve health system efficiency? Professor Martin, over to you.
Well, thank you so much for the question. I also just want to say thank you for gathering this panel and for the Lancet Commission that you are working on for the people of India. I think it's really timely to have such a commission. And today, of course, we're focusing on surgical care and perioperative care as an integral component of universal health care. which is relevant to so many countries around the world, especially in India. So while I cannot speak for India, because every time I've been there, it's been wonderful, and I've been, though, an observer to the health system. But I'm bringing a perspective that comes from a global perspective, where we can learn a lot, both from the research that we do, as well as from the policy that we are involved in developing, but not just one country at a time, quite often multiple countries at one time. So your question has two parts, I think. One is, how do we actually start to collect the data? Can we do that through the instrument of research? Or is research too much of a sort of an add-on or a bolt-on activity that then becomes something not integrated into the health system itself? And then whenever we think about research as an add-on or a bolt-on, it comes across as being something extra that costs extra money, that may or may not then be sustained for the long term in order to bring data that is reflecting the real world, but that is also sustainable. And that is something that we really need to aim for, is collecting data that has meaning right down to the patient level, but reflects the people's needs across the country, and that then is sustainable and doesn't actually require us to do extra while we're providing care. So I'm going to first talk about why we need data, and then whether or not research is a bridge to getting to the sustainable methods around actually collecting data continuously or more continuously in a way that isn't distracting from the core of care for patients as well as for policymaking. So in the world of global surgery, we, as Professor Davies alluded to, there was the original Lancet Commission on Global Surgery, published in 2015. We're 10 years beyond that now. In that Lancet Commission on Global Surgery in 2015, there were actually 6 indicators that were selected as being representative of, if we could have knowledge of those 6 surgical obstetric anesthesia indicators at the national level, then they would be sort of a proxy or a surrogate for understanding whether we have a health system that supports a productive, timely, safe, affordable surgical system. And those 6 indicators were access to surgery within 2 hours of where people live. Would they have access to essential surgery, which we've named as the bellwether procedures, emergency laparotomy, C-sections, and long bone fracture. And then the second one is workforce, and that is a per capita measure of the number of surgery, anesthesia, obstetric workforce providers that we have per capita, with a level that's been named, that's been associated with healthy outcomes at the population level. And then volume of surgery and perioperative mortality are indicator 3 and 4. And then the last 2 were indicators of financial risk protection, indicating measures of how much patients have to pay out of pocket and whether or not they are at risk for being impoverished or having catastrophic expenditure due to lack of financial resources for surgery if they have to pay out of pocket. So these 6 indicators in the original Lancet Commission on Global Surgery have since been refined by what many of you have heard about already, by the Utstein Consensus on Surgery, Obstetric, Anesthesia Indicators. And in that refinement, we, including Professor Davies here, have actually refined both the definitions, but also the data elements that need to feed into these indicators in order to have unity worldwide in definitions and the way things are actually calculated. Now, all of this to say, in our most recent 10-year update on the Lancet Commission on Global Surgery, published just in August in the Lancet, entitled Surgical Health Policy 2025 to 2035, we have updated a number of aspects, including where we're at in terms of the progress towards measuring these now 5 global surgery indicators, because we collapsed the financial risk reduction 2 indicators into one, where we're at with that globally. And this is the crux of the matter. And to put it shortly and bluntly, we have almost no example of a country that routinely, actually we have 0 examples of countries where we have routinely reported indicators for these 5 indicators of global surgery, anesthesia, obstetrics. So that tells you in a nutshell that either it's infeasible to do so, or the political will is not there to prioritize it, or there's just the lack of knowledge and intuitive understanding that this really is important. Now, these 5 indicators are there as sort of the canary in the coal mine, or those really high-level, nationally represented numbers that themselves should be reflective of a well-functioning surgical system, which we have found also reflects a broader knowledge of a well-functioning health system, even beyond the operating and perioperative system. And this has been correlated in our updated Lancet publication to other aspects, including well-functioning cancer systems and the more recent health resolution by the World Health Assembly, 76.2 resolution from 2023, suggests that, in fact, we need to think about an integrated health system across emergency, critical, and operative care. Now, I'm going to come back to and actually reflect on one of Professor Davies' points, and that is you can't do everything all at once right from the outset. And I think that's been one of our biggest problems as a community that's been focused on universal healthcare as well as on global surgery, obstetric anesthesia. Sure, we need to do most things, everything, but in our exuberance to suggest that we need immediate action because we're losing more lives than many chronic diseases or many infectious diseases. We're losing more lives than HIV, TB, malaria combined annually for lack of access to safe and affordable surgery. But because of that, we haven't had a unified voice in that. We can't do everything, because if everything is our priority, then actually nothing is our priority. We've got to actually start where we can move the needle the greatest and save the most lives with the least effort and resources possible, so that we beget momentum towards saving lives that are amenable to surgical care. So to get back to your question, we need to do this as research right now, because we have found that we don't yet have the political will and the internal data systems and the resources around those data systems in order to be routinely collecting representative data nationally and continuously. I think that's going to change very soon with our AI capabilities. We have a bit of work to do before we're there in terms of confidentiality and how to protect that data, but our capability and our capacity is changing by the day. So until we get there, I think we're going to need to do this as research and as bolt-on. Now, research in many people's minds is something that is very linear and looks like a bolt-on, but it doesn't have to be a bolt-on. The research itself can be integrated into care so that it is not an excess resource requirement. So research itself as a purposeful, intentional provision of care that naturally collects the data. What we've been doing through the NIHR Global Surgery Unit and the COVID Surge Collaborative, for example, and the Global Surge Collaborative in some of our World Health Organization research initiatives is to do short bursts of research that cross-sectionally collects the data and gets data so that we know where we're at, and then we can compare it to where we need to be based on the indicators, and so that we can name the gap and then do that routinely without requiring excess resources. That's been our modus operandi in the meantime until we get to that utopian AI enabled position where we can actually report on the data more routinely. Thank you very much.
Thank you, Professor Martin. That was a wonderful and a thorough response to a very important question. Just to follow on from there, one of the directions in which we have gone, for example, in cancer in India, is to use registries, is to identify sentinel sites. Unfortunately, the registry method misses a lot of cancer because there is a lot going on outside the registry, is not reported into the registry. But perhaps it's a start. It gives us, so we have 43 cancer registries in India now that report out relatively often as to what is happening to cancer in these centers. I wonder if you think an approach similar to that. The government has recently, over the last few years, designated a number of institutions, at least one per state, if not more than one per state, as institutions that are called the All India Institutes of Medical Sciences. I wonder if we can start to build a sentinel type process that says we don't know what's happening across the country, but at least these places we can begin to collect the kind of 5 indicators that you mentioned. I don't know what you think of that direction, because that's something potentially our commission can put its weight behind.
I think that's a great question. So, role of registries. I think registries can be an essential component within this area that spans both research as well as just routinized data collection during real-world practice. So I'm going to start with some of the benefits of registries, and then I'll round off by just talking about some of the added challenges that we need to think about as it relates to registries and whether that can inform our national indicators for progress towards affordable, safe, timely surgery. So registries are one of those things that we can integrate into our routinized daily practice. At least it gets us started. It gets us going with momentum towards a collective effort that involves our clinicians as well as our providers, as well as our institutions, and sometimes often it also involves either regional or governmental or policymakers in terms of setting up and reporting data from the registry. One of the challenges with registries is that, and we found this in our own setting, where we're starting to do more registry-based or registry-informed studies, is that we can sometimes miss the forest for the trees in that we feel deceptively like we're collecting all the data. But again, it's sort of that convenient sample that was amenable to collecting that ends up in our registry. And anytime we have data that is itself collected because it's the easiest to collect, in effect may worsen some of the very divisions or inequalities in access to surgery and inequalities in outcomes if we're not working really hard to collect all of the cases, or the cases that themselves never made it to surgery because of the very issues that we need to have addressed at a basic level. But I think I think that registries overall are one of our most amenable sources. That then we need to also think about how do we validate those registries and figure out to what degree they are representative of the national situation, the national demographic, as well as the national set of outcomes. So yes, registries, it's one of our biggest levers that we can use now. Cancer is a great place to start because we know, and we published in our updated Lancet article, that if surgery could be alone in low and middle income countries scaled up for cancer alone, we could save over $80 billion in productivity gains.
Wow.
That's just for cancer. And there's the case, the economic case, right? Just for cancer, which is not actually the highest return on investment surgery. Imagine if we did that now for lack of access to safe C-sections or, trauma-based surgeries. The economic productivity gains would be in the trillions of dollars. And so we have a huge economic case to be made. We just haven't been very good at undergirding that with reliable and routinized data. And we also haven't been very good at communicating this in a soundbite that resonates with our policymakers to prioritize it.
Indeed, indeed. No, thank you, Professor Martin. This is a wonderful set of remarks from you, and we will certainly come back to you as we, go through this discussion. I want to turn next to Professor Rahul Jindal. Professor Jindal is a professor of surgery and global health at the Uniformed Services University in Bethesda, in USA. He's a transplant surgeon, and his work also focuses, and I'm not sure how he finds the time, on building surgical capacity directly in LMICs. From what I understand from his work, his work in setting up kidney and corneal transplant programs in Guyana, as well as his role that he's playing now, and that brings him to India in exploring the community health workers' potential to facilitate surgical reference in India, are both very noteworthy. Professor Jindal, as you well know, operative care has several demand-side barriers. So far, we've spoken about availability. But on the demand side, patients may not be aware that they need surgery, or if they are aware, they may be afraid to undergo it when advised by their provider. How do we bring them into hospitals for operative care, given all the trust issues that there are? What role can community members play in that? Are there components of operative care that we can take to the community? And if so, what role do healthcare providers play there? My understanding, I'm an economist, not a doctor, but my understanding is that countries like Ethiopia have been pioneers in doing, bringing non-physician clinicians to bring surgical capacity closer to the community. Again, are there lessons in there for a country like ours? Over to you, Professor.
Thank you very much. I hope I don't have a type A personality. I trained in the UK for 10 years with Mr. Morris, learned to be humble. And I'm originally from India. I'm right now sitting right here in Ahmedabad in Gujarat, which is the western state. And most of my work here is in Ahmedabad, which has got a population of 8.2 million. And it is the hometown of Prime Minister Modi and Mahatma Gandhi and so on. So this project, as Dr. Moore said, started when I applied for a Fulbright scholarship in 2016. And of course, we know about the Lancet Commission, and I'm an adjunct to the Indian Institute of Public Health, Gandhinagar, which is India's first university dedicated to public health. And we created a consortium, a public-private partnership, but not a rigid hierarchy, between all the NGOs in Ahmedabad, which is population of 8.2 million, and Gujarat has a population of about 60 million, and the Indian Institute of Public Health. So we said we want to start at the base. So we know universal healthcare exists in India. Let's call it Modi care. I just call it Modi care, some Obama care. It's just easy to communicate. So with Professor Mavlankar, Indian Institute of Public Health, myself, we applied for my Fulbright scholarship in 2016. And basically what we said was we want to see whether Modi care is effective or not. And as a number of people pointed out, whether people are accepting it or they have trust in it. But then we said we don't want to just take the Lancet Commission bellwether cases. We want to start from the beginning. So what we did was we used the SOSAS, SOSAS, the symptomatology, and the initial study was done in 3,000 homes in a very dense slum of Ahmedabad. And just to go back, it was full cooperation because, I can speak the Indian language fluently, and my partners, the NGOs, and the politicians, they're all together in it. So there is no animosity, there is no fight for authorship, publications, to be this commissioner or that commissioner. It's a base ground work. So the first pilot we did was way back in 2000, and we took 3,000 homes in a slum, and we took another 1,000 homes in a tribal area in Sabarkantha. Dr. Moore might know. It's a very rural area bordering Gujarat and Rajasthan. And then what we did was, we said, we want to see what the baseline conditions are and what are the 5 top conditions. As people mentioned, that we can't go and treat ideally we should, but to see whether we can treat 200 conditions. So the top 5 conditions in Ahmedabad, in Gujarat, and this may not be valid for Bangalore or Orissa or Punjab and so on. When we wrote this up, there are 6, 7 publications. The top 5 critical conditions were extremity wound, kidney stone, cataracts, abdominal pain due to menstrual disorders, external hernia. So these are the top 5. So what do we do now about these conditions? So we conceptualize what we call the community health workers based on the ASHA model. So everyone knows the ASHA model, but these ASHA workers focus on antenatal and neonatal care. Now this is, we call it surgical accredited trained healthcare initiative. Now everything here, has to be an acronym, and it has to be something which people can follow. So we call them SATHI, S-A-T-H-S. So SATHI means Sakhi or a friend or. So the baseline which we came up and was approved by the Fulbright Commission again in 2000 and then again in 2024 is that these community health workers or staffs have to be from the community. They are only 8th grade education. They have to live in there and they have the trust of the people. So our initial studies, we found that the main problem was trust deficit. So it was not lack of universal health care. Now, we know people come from all across the world and they said, oh, universal health care doesn't work. There are holes, this, that. But that's not true because we did the work and we showed that the majority of the people, and we just wrote this in international health, the conversion rate and so on, which I can discuss more, is they were taking consultation, 100% consultation under Modi Care, under UHC, but they were not taking the next step and getting the procedures done. So now we are talking about these people who are daily laborers. They sell vegetables on the pavement or they collect rags. So these are, the poorest of the poor. And they would rather not work and lose their daily wages or suffer from pain and quality of life issues and so on because of the lack of trust, because there was no, so they went to, my alma mater, civil hospital and Bijou Medical College, and they waited for hours, and then the OPD got over at 1 or 2, they had to come back, or they didn't know how to go and get the CT scan and so on. So we conceptualized this Sathi project, and then we again wrote a grant for the Fulbright Commission, and we created a curriculum which we wrote up as a, so it's a 1-week curriculum, and it is tested, it's evidence-based, and the NGOs are on board, and the Indian Institute of Public Health, and the Fulbright, and so on. And then we did a pilot, and I just pull up the little numbers here. So the pilot covered the second phase, the phase 1, is from going from the pilot of 12,000 to 14,000. And we showed that there was a conversion rate of about 60%. That's a paper in International Health, that we were able to convert unmet to met needs. Now 40% are still unmet. And we did a very detailed analysis of 1-to-1 interviews and focus groups and so on. It's because we are local. Although I live in the States, I'm considered local, and the Indian Institute of Public Health, and all the NGOs, and all the politicians. And we found that people still have mistrust, and they rather trust our Sathis than surgeons and doctors and so on. So after that conversion, I came here especially to start the 3rd phase. And the 3rd phase will cover a huge chunk of the slum population. And we got funding from the Hinduja Foundation, which is based in London and in the UK, because they read some of our publications, is, we want to help. So that has started. We have now trained from 6 Sathis. We have gone to training 15 Sathis. And all the data is collected on iPad, and it is analyzed at the Indian Institute of Public Health by standardized methods. And there's 3 other things we added to the basic is the Sathis are trained to do blood pressure. They are trained to do blood sugar. And they have that Apollo kit, which is the first aid kit. I believe it was created in Bangalore. It's like a little metal box, and it has antiseptic, bandages, gauze, scissors, gloves, and so on. So they get into, now these Sathis are only 8th grade, but they are as effective as any GP. And when I come here and others, we do field visits with them, we have supervisors, and it's not like the Sathis are let loose. There is a whole supervision from the staff, from the residents of Busy Medical College and so on. They're troubleshoot by Professor Maulankar and so on. So we have now embarked on phase 3. It is 40,000 homes. It's a very big project, and we will of course report it. Now, on a side project, one of students, MSc student from Indian Institute of Science in Bangalore, he came and did a study on the quality of life and the employment gain of conversion. So he compared people in the slums who underwent surgery versus those who refused, despite all the, I shouldn't say threat, but despite all the persuasion from the Sathis and from the local public health, my partners, and the NGO. So the NGO is heavily involved. This NGO is not just any old NGO. And they go back to 100 years. You know, they're associated with Mahatma Gandhi and so on. So they have the trust of the people. So if I came like a helicopter from Maryland, I mean, no one is going to believe me. But that's how we have tried to overcome the trust deficit. So they take blood pressure, they take blood sugar, they take care of minor wounds and scratches and so on. So there is an element of building trust. Now, patients who have hypertension, they go back and measure 3 times, and then they don't treat them, but they tell them what it is and go to your local GP. So we have done what is called mapping of all the clinics around our area where we work. So our Sathis and NGO have gone to every hospital and every GP in the city of Ahmedabad, which is within 5 miles of the area where we are recruiting or we are going house to house. So we know exactly who believes in Modi care, you know, who doesn't have political animosity against the work we are doing. And we have found that, you know, people are very happy. The hospitals and GPs and those who do cataract surgery, they bend over backwards once they find that, you know, these people are genuine and it's a collaborative work. So if, as I keep saying, if I came from US, and I would find zero support, but it's a local, you know, grassroots work. So now we will be doing more. We have done 60,000 homes. We'll be doing another 100,000. And then, and a very important development is the government has approached us to see if the ASHA workers, you know, ASHA workers are across the country. And, you know, maybe 10,000 publications have been written on the effectiveness of ASHA and so on. So they want to give our curriculum, the surgical accredited, you know, 1-week curriculum to the ASHA workers and see if the role can be extended in a bigger pilot. So we have spoken to, you know, the system, the chief medical officer and the hierarchy, and I was very pleasantly surprised that they're very happy to lend ASHA workers, you know, give them paid time off, and we give them the curriculum for a week. And this curriculum is not just giving it, you know, we do a test at the end of it. It's a multiple question, and we have a paper with what test we do. When every month we have a refresher course, a CME. So they check, we make sure that the blood pressure is done correctly, the blood sugar is done correctly, and so on. And all this data is analyzed on a daily basis at the Indian Institute of Public Health, Gandhinagar, which has, you know, an enormous reputation. So if there are too many wrong blood pressure readings, like too many readings which are too close to each other, or outliers in blood sugar, then the social worker or someone will come and accompany. So this is what I am doing right now, is to build confidence. I'm doing field visits, and we will make sure that it is done correctly. So no one passes or fails. You know, all the Sathis, all the workers we train, we pay them a salary as well. So it's not voluntarism as such. We pay them a reasonable salary. So in the beginning, we asked them, what salary would you expect? And they said, those who don't know about rupees, they said, we expect 15,000 rupees a month. They said, oh, we'll pay you 18,000 rupees a month. But because it's very labor intensive work, it's very difficult. So, and you have to collect the data. You have to put it on iPad. We give you it. And we have a supervisor who's paid as well. So it's a whole grassroots effort. And as I said, we may not succeed, but I want to remove the misconception that universal health care exists in India, this Modi care, and it's quite effective because almost everyone we meet here in the tribal area, in the slum, they know about Aadhaar card. Aadhaar card is the social security card which we have of India, the biometric. A lot of people know about Modi care, and almost every person our Sathis have surveyed, they have taken surgical consultation. But the next step, actually going and doing the cataract and giving an informed consent was an issue.
No, that's a
answer. We have 6 publications. We have just submitted Sachin's work from Bangalore 1 year on the quality of life and employment gain from conversion. So he did 200 patients.
That's wonderful, Dr. Jindal. Thank you so much for sharing your perspective with us. And what you're saying in some ways, is that we have to look at the demand side as well. We can't simply assume that you build it and they will come. This is, of course, true also in primary care. But what you're saying is it's not just primary care. It's across the board that you see this as a challenge. And I think the other thing that it does, in a way, builds on both what the points that Dr. Davies made and Dr. Martin made. Davies said, start somewhere. Don't try to solve every single problem right away. And what Professor Martin said, as I understood it, is that maybe research is a gateway to starting to collect the information that we need. We don't have to wait for the high quality data systems to get built, because now you already have 5 publications, which gives us a dipstick into what the population level burdens are, what the issues are, and what exactly are the treatment methods. So it's really quite remarkable. Before I let you go, Dr. Jindal, and go back to Dr. Davies, I just want to ask you one question. Given your experience of Africa, given your experience of India, do you have any point of view on not so much referral to facilities, which of course in a state like Gujarat, in a city like Ahmedabad, where surgical capacity is of a pretty good order, when you go kind of deeper into the northern states and the eastern states, the capacity itself becomes a little bit of a challenge. Do you see any opportunity for surgical task shifting? Do you see any possibility that, like Ethiopia has done to some extent, that we can actually start to do some more of that in a context like ours? Because I worry that maybe we will have enough money. I feel like India, given all of the issues going on in the country, finance may not be our significant issue, but surgical capacity, even to ensure that there is a general surgeon and an anesthetist in every district hospital, forget sub-district hospitals. And Indian districts already 2 million people, is going to be a challenge. So any perspectives on surgical task shifting?
Yeah, so in Guyana and Suriname, where I've been 33 times and we set up the entire program, the kidney transplants are done by general surgeons. And we train general surgeons, so you don't need fellowship, like going to University of Oxford, where I spent many years. But they were doing surgeries as good. And we have a publication in the World Journal of Surgery where we compared our results with Guyanese-born surgeons doing it independently, both for kidney and cornea transplants. The results were equivalent. And what we are doing here is there's a lot of things going on which do not get the publication and publicity. in Gujarat District Hospital, Dr. Desai from Sola Civil Hospital, SOIL, from the government Sola Hospital, I met him and many times. So he has trained nurses to do cesarean section, and he has trained medical officers to do cesareans and tubal ligation and so on. So and we know from Africa that there have been general surgeons or medical officers are doing hernia repairs. The same thing is being done here. But as you said, surgical capacity, at least in Gujarat, with a population of 60 million, is not a problem. Like my original home state in Uttar Pradesh and parts of Bihar, where I go and meet my relatives, that may have a surgical capacity problem. So it's very uneven. And many of these WHO Lancet, they don't realize that there is a disparity, geographical disparity from one region to the other. So in the 5 common conditions which we studied, were completely different. Cataract, kidney stone was right up there, and malunited fractures and ulcers and menstrual disorders. So these may not be applicable for Orissa, for example, or from East Bihar. Now, even in Bihar, where I've been several times, given lectures, so on and so forth, East Bihar is different from other parts of Bihar. So that is probably a bigger problem, is realizing that there are regional and geographical issues and trust deficits. And one of the reasons why I have been able to do it is because I was born and brought up here. People see me, they think I'm one of them. I can speak the language. And the Fulbright gives a little, prestige in making things happen. But there is unlimited capacity in India to manage or, do a lot of things. It just requires little effort and bringing it together. And, people like yourself and so on is what I just wrote a paper on decolonization in DMC. We did a systematic review. The main problem is how to decolonize. So, eventually, I don't want to come here forever. I still come because it's my home. But the local people should be able to do everything.
Thank you, Professor Jindal. Turning back to you, Dr. Davies, thank you for your initial remarks and your advice. I thought maybe if I could, of course, if you had any comments on the discussion so far, I would love to hear it. But I wanted to put a specific question to you. You heard a lot of detail, for example, from Professor Jindal, and in a way, I thought it resonated well with your message of, don't aspire to solve everything right away. If you can take some things and get going with them, maybe, that can build a foundation. I just wanted you to reflect on that theme a little bit, given the context that you're familiar with, as to what might be these small starts that we could start to advocate for. And would these be hernia repairs? Would these be, C-sections? What would they be? And how would we start that journey? Over to you, Professor Davies.
Sure. Thanks very much. And thanks to previous speakers for their insights. It's great to hear everybody's nuggets of wisdom, really, really valuable. So yeah, how to go from small to large. And I'd like to think about that and also consider research as a vehicle for delivering that. I think the first thing to know is prior preparation and planning prevents poor performance. And I think that as Dr. Jindal said, everywhere is different. So burden will be different in different places, and needs will be different in different places, and whether needs are being met equitably will be different in different places. So far be it from me to step in and advise on where to start, but I think doing using the data that exist, and India is replete with data. Actually, a lot of good data in India, even if it's just from sentinel sites, there's still a lot of good data in India. So given that, to start addressing the needs that are most pressing, and considering those also with an equity lens, so that the population who most cannot access surgery to cover their needs are actually served first, and I think is the only way to start. But also, when one starts, having a plan, so that every experience is understood and built upon. And that's where I kind of bring in the research angle. We've heard about Dr. Jindal's excellent research, and we've heard about from Dr. Martin about utilizing research where we don't have data collection or other deliverables as part of the system, and that's good. I fully support those approaches, but we do need to transition to a time where research becomes integral to services. Too often we hear people say, especially with registry data, oh, that's for your research. And we need to flip that and make data collection as part of health system planning. So it's explicitly there to inform health system planning and quality improvement. And I think only then can we properly build from foundations to get a health system that actually stands on its own 2 feet and does it using data which it collects. And we tend to use research as a little bit of a crutch sometimes to prop up lack of data, and that's because we have to. But also with the right incentives, and I'm not saying monetary incentives, I'm talking about motivation. You've mentioned publications. There's also promotions. There's also purely seeing things improve. I think one can embed better data collection into one's everyday lives, and from there use that data to build services and see what works and what doesn't.
No, wonderful, wonderful. I think these are very important pointers as one goes forward to think about it. This issue of incentives that you mentioned, I wonder if, as a part of what we've been thinking about in our commission, are there ideas here that we could, for example, go to philanthropists for, go to government for, to say, are there opportunities that one could create through fellowships? Dr. Jindal mentioned the whole impact of the Fulbright. And now, of course, that's available to US nationals. But, are there equivalent ideas that one could imagine creating that starts to build out a set of scholars that use the data? Maybe because once we start using it, it'll become clearer that it needs to be generated in a high quality manner. And as you said, we need to bring research into routine practice. And it's not some exceptional idea to get one paper published and then you forget about it and move on.
Yeah, it's multifaceted, isn't it? And different people will respond to different incentives. So some people are very research minded and they like to publish, and they have that spirit of inquiry that is more towards the pure research side. Other people like to see data used for service provision. And I think as leaders, we need to identify who those people are and encourage them down whichever route suits them best. I don't really think there is a one size fits all. We're doing work in Rwanda with the use of registry data for quality improvement. And certainly within the cohort that we are working with, a localized cohort, some people are not interested. And may I say, they find it difficult to publish. So some people are not interested in it, and also they find it challenging because it's not their natural way of working. Some people are very good at it, and identifying those and finding opportunities for them, I think, is really important. Unfortunately, at the moment, we are in a time of funding scarcity. So we need to be a little bit more inventive with how we encourage these people who we work with. Can that be from ad hoc or formal mentoring with health service professionals, potentially with the WHO, potentially with university professionals? Could it be with university exchanges? That's also a potential. We certainly have a program to try and exchange students with Birmingham University, where I work. So I think this is multifaceted, and we need to again create this roadmap of how to foster data collection and data use for health system improvement through the multiple avenues, which will actually lead to that data being used.
Right, right. No, thank you. Thank you very much for this guidance. Let me turn to Dr. Martin first, Professor Jindal. Unless you wanted to have a quick interjection, I can certainly, maybe if you want to say something quick, then I will come back to you. Dr. Jindal?
Yeah, so I sent a link for a travel fellowship for 1 year, which has been created on exactly what you were saying, is that these fellows spend 3 months in different centers in India for global surgery and primary care. I sent the link there. It's a very unique, because I just sponsored Sirish Rao, one of the who worked with me. I didn't sponsor him, but he mentioned this, and I'm going to sponsor one fellow. So you might want to look at it as well. Similarly, in the Indian Institute of Public Health, we, I've created a fellowship where we fund full 1 year with MSc, but we want local grown, someone from another part, like Sachin, who came from Bangalore. He worked here for 1 year, and I funded him. And I'm looking for, more such people. But there's never enough. It's never enough.
Indeed, indeed. No, thank you. Thank you. This is a good pointer, and for us to look a little bit more at. Turning back to you, Professor Martin, first of all, of course, any comments you have on anything that's been just said, but going back to the comments you had made, I just wanted to drill a little bit deeper into, given your global experience and your exposure, are there best practices that we in India could learn from other countries that are doing good work in terms of data gathering, particularly in low resource settings? I recognize the limitations of Sentinel of, using registries, but are there other mechanisms that maybe, because in India, we have, as you might have gathered from Dr. Jindal's remarks, we have a variety of states. We have, the states that are very poor, but states that are not doing that poorly. The per capita income difference between our poorest state and our richest state is 6 times. So they're almost different countries. And maybe we could begin with, the more prosperous states and begin the journey of building data-rich systems. And once those data sets are built, then it becomes a little bit easier to go to states that may not have the internal resources. But are there examples we could study? Are there ideas that we could explore that point us in the right direction?
Thank you. Oh, it's a tough question. I think that the issue of, so from India's perspective, the different states, I think, is one of the most important things that we need to consider and sort of take a lens and figure out how to manage that. Now, every country is such a unique scenario. Even Canada has a very much distributed administration of healthcare across our provinces, because our healthcare is administered by province. But we have fewer provinces than states in India. And I'm just struck by the fact that, of course, we tend to start where it's easier and where we have the resources. So with our richer hospitals or our richer states, and again, that begets momentum and a lot of learning within that particular context. What is a bit of a conundrum is that, again, we have so many different levers to balance, don't we, when we're doing research that is for the purpose of informing both the scope of the problem and the depth of the problem, and the types of information that we gain from starting in our most resource replete areas first may or may not be actually reflective of the needs or the solutions in the context to which we hope to translate that. Though I cannot say that there is any particular clear answer as to whether you start in resource replete areas or whether you make the effort to have both resource replete and areas which are less resource replete, which don't have a voice, from which the learning may be even greater, but to which it's really hard to even start the momentum. So there's trade-offs here. I think that I'm going to step back just 2 steps and take a bit of a broader view here before we get back down to the ground. I think one of the most important things that we can do is to have a method for priority setting. And that priority setting method itself is a form of research, but it's also a form of research that a lot of people don't see as research per se, and for which there's a lot to be gained for the amount of effort that can go into priority setting that is probably commensurate with the lesser effort required in order to sort of get the bigger balls in place, for which lower amounts of efforts could actually roll out into bigger health gains. So I think if we have, and this is something we could do better, I think even on a shared global basis, is to understand priority setting, to do priority setting within our own countries that allows us to honestly assess where we're at with our surgical services provision and what amount of resource input it's going to take in order to move the needle on outputs, which gives us at least a bit of an idea on return on investment. And I think that if we could do that even at a high level, then the case is naturally made for those who are providers, but also policymakers and funders. And I know that the situation, and the context in India is different because there's different states for which policymaking, may not translate across culturally, let alone geographically, let alone by priorities. But if we could move the lever on priority setting with clarity, and also by involving our public, as well as our patients, as well as our providers, I think we would be so much more clear as to where we need to move first. Because there's a lot of things that, even with small effort, would knock the ball out of the park well beyond a lot of other things that we're spending our time on. So if we just think of, for example, the amount of benefit and lives, years of life saved that could be accrued if just the access to C-sections was made universal and with low barrier, without requiring out-of-pocket expenditure, but also in a way that is contextually relevant to the different states and sub-states where it matters to those who are accessing C-sections, how that is provided and by whom. And I also want to highlight just a flip side to that is that it's not only anymore access that is the barrier. We know that from Dr. Crook's High Quality Systems Strengthening Commission as well, that we're all familiar with, that on a global basis, access to healthcare is definitely a problem. It's definitely a problem. But in terms of the global death toll, it's the poor quality of accessed systems that results in 60% of the global death toll for diseases and conditions that were amenable to healthcare in the first place. So 60% of deaths worldwide are due to poor quality provision of health care. 40% is due to lack of access. So once we start to understand these things, two things can happen. We can become very disillusioned that nothing's possible, or we can take the upside and say things are possible. We're already providing. We just need to now get an idea of what the big hitters are and go there in a way that engages, probably across high and low resource settings equally, because the learning is rich if we do both if we do actually all areas, sorry, not all areas, but if we cross the spectrum, both ends of the spectrum of high and low resource sub-regions. And then lastly, if we simplify it even further, because health systems and surgical systems are complex, we can really get mired in the details. But if we just focus on the people, and this is the simplifying lens, whether high income, low income, high resource, low resource, with a voice, without a voice, we just honestly, intentionally focus on the people who we're serving, then it becomes very simple that we just simply need to prioritize even at a high level and figure out biggest gains first for the amount of resource input and go do, and then the momentum begets itself and the case itself is made. But again, we need a unified voice in this regard, and sharing our experiences across countries with priority setting and the return on investment, I think that is a lever that's far underused. And I also think that the Lancet Commissions, broadly speaking, are a really good instrument to communicate that as well.
I think that's very wise advice, Dr. Martin, and something that we need to reflect on carefully as we start to build out. Both yourself and Professor Davies have really stressed this idea of priority setting, of making sure that we understand what is needed, and then really build from there to make sure. And I see your point that, you know, while it may seem appealing to start where the high resources are, we have to be careful that we don't end up conflating the requirements of a high resource setting with that of a low resource setting, which maybe have an entirely different set of issues. There may be some common ones, but there could be some entirely different set of issues. So thank you so much. It's wonderful to talk to all of you. We are almost out of time. And there's one question, Dr. Jindal, from I think your former student, Mr. Sachin Iyer, who wants to know that do we have any comments on the difficulties of encouraging medical professionals to practice in rural or remote areas? Maybe, and what have other people done to address this issue? Sachin, works now in rural Maharashtra.
Maharashtra, yes. We
And
both know him. He is one of the finest students here, And as I was saying, I created this of my own fund, and I'm looking for, and I tell them, I give them the thesis. And before that, Ankita Shah, local, she did a PhD at IIT, so I tell them, I'll pay for everything if you come and work like Sachin in Ahmedabad, not remotely making policy,
Right. But
You have to
any thoughts that any of you have on, his question that, how do we get people to come and work? Any practices that you know from elsewhere?
Having been born, brought up in India, doing all this, we need to change the political system, as you know. People go, the physicians go and work in rural areas for a year, 2 years, 3 years. They get some experience and then move into the bigger towns and cities. So that's a problem. You can't really force anyone to go and work in the rural areas.
Indeed.
Unless you are, like Mahatma Gandhi or one, or Prime Minister Modi, my good friend, I've known him for 40 years. So someone like that, which comes intrinsic, or Nelson Mandela, but you can't force anyone. You have to improve the infrastructure. You have to improve the schools. A lot of roads and highways being built in India, so that's not a problem. But the whole ecosystem has to change, and we need people like Sachin and who are prepared to sacrifice, and to give a plug for Fulbright Nehru. They selected me, a surgeon, to do this work. And everyone said, "Oh, you have type A personality. What are you going to do?" You need humility.
Well, thank you all for your wonderful comments. I won't keep you longer than we had promised you. I know many of you created time, and squeezed it out so that you could be here. And I'm really, truly grateful to all three of you for sharing your perspectives so openly and giving us very good guidance on an important, I'm taking away many lessons from these conversations about the direction that we here, sitting here in India, need to head. And I will, of course, work with Siddesh, who, knows this field much more intimately than I do, to summarize some of these conversations so that they can both feed into, our own work at the commission, but also into a larger conversation in the country, because I think these are ideas that need to be heard much more widely in the policy space, and we need to find a way to move them forward. So we are almost at time. I'm just going to ask quickly the Harvard team, Shreya, Shubhangi, anything that you need us to do before we sign off? Siddesh, is there anything else that we might have missed that you want us to say? We just have a few more minutes.
Nothing from my end. Like this was amazing. Yeah. Thanks so much.
Thank you, Siddesh. Shreya, anything in closing that we need to do?
No, thank you so much. I think thank you to all the panelists for coming together. Thank you, Siddesh and Shubhangi, for all your efforts and coordination. Thank you, Angarika, for putting across everything on the chat box. Thank you, everyone. Have a good evening.
Thank you very much. So we will say video good night, good morning, whatever it is the appropriate time at your end. Thank you.
I usually end with a namaste.
Namaste. Yes, indeed. Particularly during COVID, it became a global symbol. Thank you so much. Bye-bye.